Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hi, everybody. Dr. Mark Sims here. I'm the host of the Listen Up podcast, where we feature leaders in healthcare. This episode is brought to you by Arizona Hearing Center. I help patients to effectively treat their hearing loss so they can better connect with friends and family and remain independent. The reason I'm so passionate about hearing loss is I lost my brother Robbie twice. First to hearing loss from radiation from his brain tumor, and then complications from his brain tumor. I am the founder of Arizona Hearing Center. I'm the E of ENT. I only treat ears. I've performed over 10,000 ear surgeries in my 20-year career. And I also treat thousands of patients who have sensorineural hearing loss or nerve hearing loss. If you want to learn more about my book, which I'm an author of, it's called Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. You can go to www.listenuphearing.com, or you can go to my practice website, which is www.azhear.com. I am really excited today. I have Dr. Briana Auman. She is a clinical neuropsychologist specializing in aging and neurodegenerative brain disorders. She earned her doctorate degree in psychology at Yeshiva University in New York, and then she completed a 2-year postdoctoral fellowship in the Department of Neurology at the University of Virginia Health Services. She now joined the Banner Sun Health Research Institute, and she provides outpatient neuropsychological testing. She also supervises graduate students and helps run their Brain Health Check program. It's a free community program to see if you have cognitive problems. Outside of work, she spends her time gardening and working on her new house and exploring restaurants in Phoenix. I'm really excited to have her here. Welcome on the show.
Oh, thank you for having me.
Oh, my pleasure, man. Can you tell me, so I always want to tell people so now you're a neuropsychologist who specializes in aging, who as a background for the listeners, who also did a podcast on hearing loss and dementia, and we've worked together before, but we don't want to get that far. How did you go from being whoever you were to being a neuropsychologist? Tell me your pathway to that.
As an undergraduate student, first of all, entered pre-med. So I wanted to help people, wanted to do something in the healthcare field, but it turns out I wasn't very good at chemistry. But it was the best failure ever because it led me on the path that I am now. So I switched to psychology and was so excited about helping patients through therapy, counseling, things like that. And then once I finally got into grad school, years later, I realized that was really hard without having a decent assessment of what the problem is to begin with.
Sure.
So I wasn't making much progress there. So that's what led me more towards the assessment side. And as you get deeper, each layer of asking, well, why do they do that? Why does their brain do that? It led me into neuropsychology.
So when you say the assessment side, can you expand a little bit more? I mean, I know what you guys do, but can you, for the listeners, explain what that means?
Sure. So in psychology, there's all different kinds of tests, right? Tests of personality that you can even take online now. Back in the day, there was like the Rorschach ink blot test to test your personality, your mental functioning. And those capture traits really well, but I felt like I was still kind of missing the underlying neuroscience piece. Like, where is all this coming from?
Right.
So that made me want to specialize adding in the brain part.
Okay, and so you do end up testing of people to see how their brain is functioning?
Yeah, so that's what we do now. We do end up testing the end result of all those electrochemical signals in the brain. That's memory, that's attention. And so that's what we end up measuring, try to infer what's going on inside.
So what type of reasons would patients be sent to you for evaluation?
In my clinic, at least, it's mostly people who have concerns about their memory or some other aspect of their thinking that they feel like is changing as they're getting older. So that's always the big question for me is, well, is that a change for you?
And so how do you assess that, if you don't have a baseline, right? Like, so they probably didn't come in to get testing and say, well, now I'm thinking normal and my memories are good. So let me go get a test. So then if it changes, so how do you do that?
I wish that everybody did have a baseline. So I always feel like it's okay.
I'll schedule mine then.
It's a great idea. So we kind of call it like a checkup from the neck up. You go in every year and get your heart tested, your blood pressure, your A1C for diabetes, but nobody thinks to worry about their cognitive functioning until they have concerns. But since we're not at that point yet, we try to get an estimate of cognitive functioning based on some general factors like education, what someone did for a living, what their skills would be. Someone who worked on jet engines is probably going to have a lot stronger visual problem solving than their verbal skills. But we also have some tests that really aren't affected even by the changes associated with aging and dementia. So we can use those to estimate a baseline and compare everything against that.
So what's the most unusual occupation you've had a patient? Because I can't imagine it's not somebody like, wow, I never thought anybody did that for a living.
That is a great question. I have met many people who work their whole careers as self-published authors, and I never knew that was a possibility.
Wow. That's that they write all day and are able to sell enough books to make a living.
And they get to keep doing it, like I would say into retirement, but they're still working, but well into their 70s and 80s.
Wow. They must have had like dozens and dozens of books. Having written one book, that's a lot of work, I'll just tell you. But for some people, it's a love, obviously. And so do they get referred by family, friends, their physicians? How does one get to you in terms of not the physical calling of the phone number? I mean, what is the typical pathway to you?
Typically, people will show up to their primary care doctor's office and during their annual Medicare visit, mention, I do have some concerns about my memory. And their primary care doctor might do a short cognitive screening. Hopefully, either way, he'll refer them on to us because those short cognitive tests don't always pick up on things.
Right.
And they'll see one of the neurologists at our clinic, and 95% of our patients who see our neurologists also get cognitive testing, which is an important piece of the puzzle.
So one of the things I mentioned in your introduction was, the brain health check. Right? Mm-hmm. So what does that program compose of? In other words, if somebody's going to get a brain health check, what does that mean?
We just started this program about 2 years ago, and it's a totally free community service. So people don't have to be a patient of any particular clinic, and you don't have to sign up for any research. It's just that we felt that a lot of people were being missed. Getting that cognitive screening, maybe at their primary care doctor's office. So what it is people do a short cognitive assessment, about 15 minutes, and then we put that into an algorithm that compares that to what are the expected results. And actually, the important piece is give them a printout that shows where you stand related to what we would expect and concern.
So it's like your vitals of your brain.
Exactly.
So what does that test consist of? Is that the MoCA or what is it?
It's like a MoCA plus. So we do a MoCA, also some additional tests of language and visual spatial skills that we kind of felt weren't really captured there. And then some questionnaires. And one of them is about objective changes in thinking and daily functioning, because that's actually been shown to be a really important predictor of later cognitive change, even if their brief cognitive testing looks fine.
So for the listeners, the MoCA is the Montreal Cognitive Assessment. And so that's a test that people can be taught how to do to initially screen people. And so, correct me if I'm wrong, did I just hear you say that people, their own awareness of their cognitive issue is one of the most predictive things of them having cognitive problems?
Right. So, for example, in our screening program, if someone endorses concerns about changes in their functioning over the past couple of years, even if they perform well, they'll still be in our high risk category, and we'll recommend that they get some additional evaluation.
Yeah, I think it's interesting because, if you think of athletics, right? I mean, if somebody was performing at the level of an NFL player, right, and then drops down to playing at the level of Pee Wee, for many of us, playing at the level of Pee Wee might be great, but for those people, it's a huge performance decline. So it is hard because it has to be normalized to the way you're used to functioning, if I'm not mistaken. Right?
That's exactly what it's designed to capture.
And so how about loved ones and spouses? Are they highly predictive of cognitive issues? A wife or a husband or a loved one, are they highly predictive of cognitive issues.
Yes, and that's actually a part of it too. If someone coming in to get a brain health check-in chooses to bring someone with them and is okay with their person with them also filling out some of the questionnaires, they have the exact same questions. We get their perspective too, because that's also been shown that it can predict later cognitive decline.
So I guess the takeaway could be if your loved one's telling you your memory's not as good as it was, it probably is not as good as it was, right? Because really, like, why would a loved one tell you that unless it were true, right? I mean, unless they're the meanest person around.
Exactly. They don't want to hurt you. And if anything, it might come up during that meeting in our brain health check-in and never was mentioned before because nobody's asked.
I've always, one of the things that fascinates me about medicine is like utilization. Like, so of the people who should, what percentage of people are actually coming to you? In other words, you have a predicted size of a patient population that has this problem. And then of that predicted size, what percentage are actually getting this type of evaluation today? I bet you it's small, unfortunately, but I'm just kind of wondering.
Yes, there's huge proportions of untreated dementia. Unfortunately, especially in the populations that are most at risk. So some of our underserved populations, whether that's based on their demographic background or where they live, like in rural areas, the epidemiological studies show those people are most at risk of developing dementia, but they're the least likely to seek out care.
Right. So is it a small fraction who should be evaluated are getting evaluated?
Yes. I think it's growing though, because I think awareness of Alzheimer's disease and other dementias kind of along with it, but we'll take it.
No, that's great. I mean, and so is there outreach to the primary care doctors about this issue, or what does that look like?
Yeah, that's funny. You actually mentioned another new program that we have here. It's called Dementia Care Partners, and they train health coaches to work with people with cognitive problems, and it's all done through primary care. So it's made to try to reach out to those people who don't get into a neurology specialty clinic, but still need the psychosocial support. So based by just reviewing medical records, we're affiliated with a few different primary care doctors here in the Sun City area, and just look for signs that there could be dementia, some sort of cognitive problem, and then reach out to the doctor. And if they say it's okay, they go right to the patient without all of the testing in between.
So you guys are prospectively looking at charts for this? Is that am I getting that correctly?
It can go both ways. So they're reviewing charts, looking for like certain keywords, and then also the doctors can make a referral directly to them if they think it would be helpful.
Are you using artificial intelligence or something to do
In power.
Wow, just reading it, right? The grunt work of reading it, right? And so are there particular questions that primary care doctors ask on a regular basis that are more predictive than others? Do you see what I'm saying? Like, people will always ask, like, how many flights of steps can you go up without getting out of breath? For instance, is a very typical question a primary care doctor will ask to see if they have heart disease, right? So are there some that are in the standard corpus of questions at primary care that are maybe more predictive of dementia? I'm really kind of just wondering out loud what else.
I think in general they'll ask about have any concerns about your memory. I think the depression questions are also really relevant. So the questions about mood could be a sign that there's depression because there's things to worry about in the world, but they could be a sign that there's some brain changes happening too that are changing emotional processing. But I really like the functional ones, like who takes care of your medication. And if it turns out over the past couple of years, a lot more responsibility has shifted to the spouse,
right,
there's some loss there.
Yeah, no, that makes sense, right? Because you got to put them in the hours in the day box and all of that stuff, so that is some calculation and memory of whether you took it or not. So, well, I know one of the things that you and I have talked about is hearing loss and dementia, and I know one of the reasons I circle back to is you had done a prior presentation about it. And so tell me your take on that whole connection. It's become, the literature, the research is becoming stronger and stronger. So, if you could speak to, what the thinking is of mechanism or prevalence or those types of things.
I think the mechanism question is what they're investigating now before we even get there. So I thought that it was really interesting how I was reviewing the literature and finding, like you said, more and more evidence. And then within this past year, it finally got recognized by those big epidemiological studies. And then that gets picked up by something like the New York Times, just spurs even more research into it. But hopefully now also makes it a lot more accepted among just the general population that hearing loss can be considered something you can do to prevent dementia.
Yeah. So, what's very much about us is the Lancet position paper on dementia and modifiable factors. And so, what's coming through our literature is that hearing loss is the most modifiable factor at a large, like fivefold over, lowering your cholesterol, blood pressure, which are, exercise and blood pressure have always been the two things that people have been told to be preventative for dementia. And it's kind of interesting that they're finding the magnitude of impact is greater for hearing loss.
And I'm really interested in the fact that it's so much more than things we can't change, like genetics, which everyone's always worried about.
Yeah, I always tell people there's a lot of things you can escape, but you can't escape your genetics. So
Luckily,
go ahead.
Stuff counts more.
I'm sorry.
Luckily, some of these modifiable things count even more.
No, it's true, but I guess I'm talking about overall diseases, right? Not necessarily dementia. And so you also train students. What's that like?
Yes. So our students' primary role is in our brain and body donation program, where participants come back yearly for a range of assessments, and one of them is our cognitive assessment. And that's staffed by our students. They're graduate students, usually advanced towards closer to graduation than starting school. And they're here to learn more about neuropsychology, get experience working with older adults, and really learn how to give the tests in a nice standardized format. So every year I've learned that working with students makes me realize how much I don't know, because they always ask questions that we all have to just look up together. So it's so good to have that fresh perspective every time.
And so what other type of, research projects do you guys have going on at your institute in terms of dementia?
Lots and growing is something I'm learning. But I was thinking about this, and it really lines up with our talk about hearing loss as a preventable risk factor, because one of the big focuses is prevention studies.
Right.
Some of them are just observing people over time to see what are some of those other risk factors. And then some are a lot more active with testing out a drug that could potentially treat or reverse those early brain changes.
So you guys are basically touching memory problems and dementia across all the spectrum: detection, prevention, treatment, cause, pharmacology, all that stuff.
That's what's really cool. That's actually what drew me to Beeshry, was that there's all these different intersections of ways that they're trying to address the same problem. So I never worry about being out of a job. What if they cure Alzheimer's disease? What are you going to do?
There are other diseases that need to be. Right. Well, the other question is not to be, but if Alzheimer's gets cured, there will likely be cognitive degeneration of other mechanisms that will need to be addressed. Right?
Yes, absolutely. And in the meantime, we can still help assess everyone's strengths and weaknesses, which could exist with or without Alzheimer's disease.
Right.
And still focus on how to improve cognitive functioning. So I don't think that's going away anytime soon.
Right. And so how often do you see patients with hearing loss?
Patients with admitted hearing loss is probably 50% of the time. I now know that actually having hearing loss at low levels that they don't even notice is probably 100% of the time.
Or a little bit less, but yeah, it's pretty prevalent, that's for sure. 80% of 80-year-olds have a treatable hearing loss, so as they get older. And I assume the age of your average patient is relatively high based on your location in Sun City.
Yes, we actually don't see patients under 60, 65 typically. We really specialize in older adults.
Oh, I didn't know that. And so just as I was just thinking about it as an overall in your institute, how many people are involved in the institute, like in terms of staff? I mean, it's pretty big if I recall, but how many clinicians and people are involved?
I'll start small with our department, even has grown over this past year. So we have 2 full-time neuropsychologists, but also postdoctoral fellows. So myself a couple years ago.
Right.
They really get to function like neuropsychologists, and 4 psychometrists, and then also senior psychometrists, coordinators, and assistants. And that's just our team.
So are psychometrists people who administer the tests?
Yes, they have the hard job.
Okay.
You talk with patients, learn about their background, interpret their data, but they actually collect it.
Right. Okay. And so that's just your department, multiple other departments, right?
Yes. So we also have neurologists and neurology nurse practitioners. Of course, all of our awesome medical assistants and front office staff, and our science researchers in the autopsy lab.
And statisticians, you must have all that support too, research support.
And then it kind of depends how far out it goes, because we also have our sister campus, the Banner Alzheimer's Institute downtown, and we basically mirror each other and do the same thing.
Wow, that's amazing. That's amazing. So, if somebody wanted to get an evaluation, what things would you tell them they should be looking for? Or what are the things that you would say, hey, if this or this is happening, you should consider getting an evaluation, just as a general guide?
I think one of the big things is thinking about, is this different than myself just a couple years ago? Of course, everyone's going to be different than they were when they were a young adult.
Right.
Even in midlife. But if there's been a big change in how sharp you feel or the things that you do, you notice that your world has kind of gotten smaller. But really, specific things that people often tell me is forgetting conversation. If people start saying, we already talked about this, remember? That's a sign that it's definitely worth checking out.
Because that's a short-term memory issue?
Those long-term memories, that if I had a nickel for every time I heard, but I can remember things from so long ago really well. Those are really resilient. They typically aren't affected by any of these neurodegenerative diseases.
But they're also landmark memories too, right? I mean, they don't remember what they had for breakfast on their 9.5 years of life. They remember big events, right?
That's the silver lining, is those important memories usually don't go anywhere.
Oh, that's great. That's encouraging. So, other questions I always love to ask people. I always ask people, who would you thank if people said to you, you're getting an award, lifetime award, and I want to thank, who are those people you would thank who helped you to get where you are today?
So I have to start with my husband, who's followed me around all of the country for this different training, and finally did us up here in Arizona, which I think was our biggest adventure. And then also my parents, who I was thinking back about the journey question, and they've supported me even when I was a little kid, and I was one of those kids who always asked, why? They never told me not to worry about it. Instead, they said, let's figure it out. So I really appreciate that.
That's awesome. Those are great stories. And then the last question is, being that it is a hearing podcast, what's your favorite sound?
Coffee brewing in the morning.
That going through that gurgling sound, are you talking about, or just the drip sound?
Mm-hmm.
Right. No, I mean, the reason I was asking people that is because, as somebody who's in hearing loss, it's just thinking about what are those pleasurable sounds, and you no longer have them, right? And so that to me becomes a real big deal, right? So it's a way to contextualize, what for people to understand. Think about that. What is the most amazing sound you have? And imagine if that went away. And unfortunately, as you know and I do, that's hearing loss. So.
Exactly, and that's a signal to me every morning. All right, time to get going on another day. So that goes to show you how without that hearing, without the sound, you don't have those triggers to.
Right. Very much so. Or an alarm, as a practical matter. That's what alarms do, right? So if people, Briana, they want to get a hold of you, how could people get a hold of you?
So on the web, our website is bannershri.com, and that lists all of those different things we were talking about, all the different ways we're working on dementia. And of course, if you talk to your doctor about memory concerns and you want to come see us, then eventually you'll come to me.
You're going to get to her sooner or later.
Basically.
Well, this has been great. Everybody, we've had Dr. Briana Auman. She is a neuropsychologist at the Banner Sun Health Research Institute. This has been great to have you visit and share about dementia and neuropsychology. And I really appreciate you coming on today. This has been excellent. Thank you so much.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.